So this is another very important thing that we needed to iron out. It is believed, again, that lobular cancers are really responsive to hormonal therapies. They are treated similar to ductal cancers in terms of the first line they receive, usually an aromatase inhibitor in combination with a CDK4/6 inhibitor. Now, we already published on that before in 2023 that patient, whether they have lobular, ductal, or a mixed histology, benefit from the same first-line therapy of this combination. The idea is, until now in the NCCN guideline, it's approved or it's one of the recommendations that you can use single-agent fulvestrant in second line. And I see this practice a lot in lobular patients, especially that they say, oh, these are hormonal-driven cancers, so we need to give them, exhaust all the endocrine therapies before we move on. So we do have some studies that came comparing single-agent fulvestrant to new oral agents, new oral SERDs, and it's showing that really fulvestrant single-agent have an abysmal progression-free survival, doesn't really work that well. But in those studies, I didn't look at ductal versus lobular. And for that reason, it's really challenging when we're trying to do studies to find historical cohort that looked at single-agent fulvestrant so we can build upon and convince whether it's applying for grants or talking to pharma companies to do a better combination for the second-line group of people that usually do receive single-agent fulvestrant. So we wanted to establish this historical cohort. So we dig deep in our prospectively collected database at MD Anderson for patients with lobular breast cancer who received second-line fulvestrant after they have received the prior CDK4/6 plus an aromatase inhibitor. And we found it doesn't really work. The 6-month progression-free survival was less than 20%, and nobody stayed on the drug for a year. So the 12-month progression-free survival was 0%. So this shows that this is an area of unmet need for patients with lobular breast cancer after they progress on aromatase inhibitor plus CDK4/6. And this is something everybody that's worked on lobular can use to put as hypothesis generating of improving outcome. For example, I can say combination X plus fulvestrant, I'm anticipating to double the 6-month progression-free survival. So what we reported was about 17%. So we say this combination will be doubling than that. So it gives us a nice benchmark standard that we can build upon to improve outcomes.